All right, awesome. So I usually start these conversations with some unexpected question. I was looking at your background. It seems that a few years ago you had short hair.
Yeah, I do triathlon, and so I cut my hair to kind of just because I was working out a lot, and but I still do triathlon, but it's growing out now.
Both look great on you, but I was first of all I was like maybe it's not her, maybe something. But it was like everything was you, just the hair wasn't that. So I thought I should double check.
Yeah, I cut it. I think it was my third or fourth year of residency. I just I was trying to get through residency and working out, and so I just cut it really short so I didn't have to worry about it as much. But now I have more time, so I can have long hair again.
Okay, so triathlon. You have a thing. You have a stamina for hard things. Obviously, that's why you are into complex gynecologic disorders.
I think yeah, that sounds about right.
Cool. All right. Let me read something here. Dr. Nicole Kretzer, board certified gynecologist, focused on complex GYN issues such as fibroids, endometriosis, incontinence, and prolapse in a multidisciplinary setting. Is that accurate?
Yeah, that is my passion. I've spent my time since residency focusing only on gynecology, and I initially trained with Dr. Winner, learning more in depth about the medical and surgical management of fibroids and endometriosis. And I did that about half time, and then the other half time I worked with a urogynecologist, and so I got in-depth training regarding urinary issues, urinary incontinence, and prolapse repair.
That's great. Yes, when I read this about you, and also Dr. Wiener sent me an email. Just I asked, she wanted to give me some idea about you, and it was great because you probably know it already. A lot of patients with endometriosis, they have a lot of urinary complications, like different complications. I don't want to name them. So this could be a very unique combination what you got as a background
Yeah,
for.
I think it's very helpful because a lot of them have like bladder pain syndrome or have been diagnosed with bladder pain syndrome, otherwise called interstitial cystitis. And so that's something I'm very familiar with and comfortable managing and treating along with any symptoms they have from endometriosis. And I think a lot of times the kind of inflammatory environment that gets created kind of makes those conditions exist together. And so it's good to be able to manage both.
Yeah, that's great. How do you manage painful bladder syndrome or endometriosis cystitis? Like, what is typically the standard of care for them for a patient with endometriosis who has gone through endometriosis care or surgery or whatever needed to be done now still has interstitial cystitis?
So, interstitial cystitis, unfortunately, is a diagnosis of exclusion, which is a very unsatisfying type of condition to have, meaning you look for a lot of other things, and if it's none of those things and they still are having painful urination, that's kind of the name we call it. And the reason that is we need to rule out other causes of their symptoms. So we need to rule out that they're not having frequent urinary tract infections, that they don't have like conditions like urinary frequency and urgency due to overactive bladder, or incontinence due to overactive bladder or stress urinary incontinence. And so we rule out all of those aspects of kind of the urinary symptoms, and if their predominant symptom is frequency and painful urination, then we empirically start treatment for interstitial cystitis. You can diagnose it by doing something called bladder installation through a cystoscopy, which is a procedure where you put a camera into the bladder and you kind of fill the bladder up, and when you and let it kind of be full for a little bit, and then you let it drain, and then you may see these ulcers called Hulner's lesions. But you only see that in about 50% of patients, and so um, I, it's not a good way to diagnose it. So really, if patients are having symptoms from it, then I think treating them is the proper way to go to see if that helps improve their symptoms and improve their pain.
Yeah. And is there any data, any statistics about what percentage of endometriosis patients will have endometriosis cystitis in their lifetime?
I don't know that particular data. I do see a lot of patients that have endometriosis have bladder symptoms, and sometimes when we treat the endometriosis, their bladder symptoms do go away. So I do think some of the bladder symptoms can be secondary to the inflammatory nature of uh, endometriosis, and that's I don't know if there's a lot of data on that, but that's just my perception of when we excise their endometriosis, they feel better and they have decreased pain and decreased urinary frequency. And so in my patients that I'm working up more for endometriosis, I usually recommend let's treat your endometriosis first. And if you continue to have pain with urination, then we'll go down the pathway of empirically treating for interstitial cystitis and see if that helps improve their pain. I think in general, pelvic plane is really complex. You have a lot of organs in a very tight area. You have your bowel, you have your uterus, you have your bladder, you have nerves and muscles, and inflammation or pain in any of those areas can kind of lead to pain in the other just because everything's very tied together through the pelvic floor. So treating any of these diseases involves kind of treating all of those aspects and that's why we've extended our practice to this multidisciplinary care model because medicine and what doctors can do is only so much, but doing things like an anti-inflammatory diet or especially for interstitial cystitis doing like a elimination diet to eliminate bladder irritants can be really helpful. So dietary care can be really beneficial to patients. And then pelvic floor physical therapy and acupuncture can also be really helpful for these patients since everything is so intricately like tied together.
Yeah, I'm glad you mentioned this because that's exactly where I wanted to go with the multidisciplinary care. So you are part of the full spectrum endometriosis fibroids clinic in Seattle, and so it's a new practice launched in November, I believe. And so it's a holistic care approach. You offer surgery, post-surgery care, long term, and also these alternative modalities including lifestyle diet. So can you tell us a little bit about your philosophy? Why do you think this holistic, like multidisciplinary approach is required for these patients? Because not many people do that, but why are you doing it? Like, what's the philosophy?
I think a lot of these patients, their main primary symptom is pain. So pain is really complex. There's also psychological component to pain, and so I find that even though our goal with any of the interventions that we do as doctors, either medically or surgically, is to reduce the pain, that sometimes we're not able to completely eliminate the pain. And I want our patients to know that that doesn't mean that we've given up on them, and I don't want these women to have to live through pain. I want them to have good quality of life and to be able to do whatever they want in their lives and whatever goals they have. I want them to be able to go to school and go to work and have a family if those are what they want. And so I realize that we have limitations as doctors. And so trying to bring in all these other approaches in order to have this holistic approach to really tackle pain from multiple perspectives, because I can't promise that everything I do will make their pain go away, even though that is what I want for them. And so I always tell them when they come to see me that a lot of times they've gone to a lot of different doctors and they feel that they haven't been heard about their symptoms. And I want them to know that I hear them, I'm there for them, but it's a journey. And sometimes I don't have all the answers either. And so we need to work together to try to do what I know within my practice that can optimize their condition, but then incorporate these other modalities and also to provide them care to really give them the most benefit possible.
How difficult is it to change a patient's perception? Like, for example, I mean, obviously patients, no one wants to be in pain, and no one wants to spend years in pain, and no one wants to have 10 different stuffs to get through before they feel better. That's like counterintuitive. Intuition is, can you just give me a pill and I feel better tomorrow? Right? So endometriosis is so counterintuitive in many ways. Now you have patients who have been through this for years, or maybe not, but mostly have been through this for years, coming to you and you're telling, so the mindset is still there. Can you get me fixed? If not, maybe you are one of the other ones that I've seen in 10 years. Now you're starting this new conversation that, all right, look, this is a long-term disease. You have had it for many years. This has caused damages anyway. It's not going to go away overnight. So now we are, how does that play, like I'm curious about patients would react to you when you tell them this.
I think for the most part, they feel relief because they feel heard for the first time and they realize that I'm on their side. And that's how I want them to feel that pain is really complex. You know, there's whole specialties devoted to pain care. And so most of them are pretty positive. At least they have some hope that, you know, even if we do a surgery and we don't find any endometriosis, I mean, that can happen. But that doesn't mean that I have give up on them and that I send them away. It just means we need to look at other things. We need to focus then on your bladder or your bowel or your musculature or just the level of pain at which your receptors are firing and work on ways to reduce that. And so we've built out the network with the care model in our clinic, and but also I have consulted with a lot of the pain doctors from like PM&R specialty and sports medicine that do a lot of like pudendal nerve entrapment and other type of like steroid injections for pain. I have a network within Seattle that I will refer patients to as well in order to optimize their care. So I think for them, nice that they have someone that is trying to look in a holistic way and not just say, you know, we didn't do enough, goodbye.
I think it's I really believe this could be a a unique experience, because that's not typically how care works in this country, right? This care just, I'm doing this, if it's working great, doesn't working, but that's all I could do. Now this model that you're advocating for and basically performing for your patients is just, all right, let's sit together. It's a problem solving journey. We have this list of things to do, first to pinpoint the source of the problem, then to give you a solution. I think that, and this can take, I'm really thinking patient's experience is probably going to be so different with you. Like they will probably go home and say, wow, this was like a completely different experience, although they have been through hundreds of medical practices, and they think they haven't, there's nothing new that can surprise them. Have you heard this? Have you seen this? Like, wow, this is different in your patient population.
Yeah, I think we do see that they're happy that we're listening and that we're not just going to, you know, do the surgery and send them away. And I think it does give them some hope, you know, but I still don't have all the answers and I can't guarantee anything, but at least we're going to try and try everything within like the literature that I read and with the collaborators that I have and their expertise. And so but we are able to do that because we had to start this practice. In order to do that, we couldn't do it within a conventional model and hospital system where we worked before.
Yeah, I think that's exactly why practices, why people like you go out of the conventional model, because in my opinion conventional model is not built for complex diseases. Like it's so fragmented that the system is like so old, and it's just hard to move it. It's hard to move it for complex diseases that have been historically overlooked. Right. So let's get back to you. I think so. When you went to medical school, then you did an MD, PhD, which shows. I mean, everything about you shows some stamina. Everything about you shows like you are not gonna give up. You are not gonna like be happy with superficial, shallow things. You need to go deep, and you need to like know what's going on. So that, I think that's really you, in my opinion, in everything you say about your sport, your career choice, and your background. And then, so after that, you did the residency. Like, what made you to make that decision? Why MD, PhD? Like, what was the driver of that decision?
So originally, when I was in undergrad, I kind of was focused on research initially and thought that I would only do a PhD after my undergrad, which is kind of atypical of people going into medicine. They're usually like from the very beginning, they want to be doctors. And I was in a lab in my undergrad doing breast cancer research actually. And um, you know, I was working with cells and a bench top, and I kind of craved being able to actually see the patients that I would have been doing these therapies for and interacting with patients. And so I pivoted to do the MD PhD. And so that's why I originally went into the MD PhD program. And so I did both the MD and the PhD at Washington University in St. Louis. My PhD was in immunology because I think the immune system is extremely complex and really important. At that time, I was really focused on cancer immunology, which was actually just starting to boom during my time in the lab. And then really actually enjoyed working with a gynecological oncologist during my medical school rotations. And so that's what led me to go into OBGYN. And I thought throughout my whole residency that I would end up applying to gyn-onc fellowship and taking that path. And then just life happens, and doing a fellowship is really, it's a lot of work, but you also have to move a lot of times, and that just wasn't something feasible for my life situation. And I had worked with Dr. Winner as a resident, and so she was needing someone to be her assist as a surgeon at that time as well. So we kind of became a good pair, and that's how I started working with her. And so I still get to do my, gynecological surgery, which is what I'm really have always loved doing, and but now focused more on these complex gyn issues for benign gynecology, which actually I think there's a real need for that, and a real need for people that know immunology for these diseases, because there is a huge immune component. And so I think that makes me kind of in a unique position for this area.
Yeah, yeah. So you were Dr. Wiener's resident at University of Washington, huh?
Yeah, as we rotate in the different areas of obstetrics and gynecology, there's a minimally invasive gynecology rotation. And so yeah, I worked with her for that rotation. And I kind of already knew about her. She actually was at Washington University in St. Louis when I was there for my MD PhD, and I didn't actually talk to her then, but like I knew of her. But then, those ties kind of, we talked about those ties, and that kind of created a bond between us, that then as I was trying to find my way, knowing that I didn't want to do obstetrics anymore, and I wanted to focus on gynecology, and she was someone that was doing that, and she kind of became my mentor on that path.
Interesting. So that's how you got into endometriosis, and this connection and this like path of getting into mix, right? That's how you chose endometriosis.
Yeah, so immediately after residency, I did research in a lab at University of Washington called the Cancer Vaccine Institute. I was still working on some ovarian cancer research and immunology, and related to that, they do cancer vaccines. And I was looking more at ovarian cancer at that time. And then to keep up my surgical skills, and to keep working in the clinical arena, I was working with Dr. Winter. And then as I became more passionate about that, my time in the lab decreased and my time with Dr. Winter increased. And then I also, as a part of that group, the urogynecologist was a part of that kind of group where we were working. And so that's how I started working in that environment as well.
So when you started with, I have a lot of questions about the immunology and cancers for ovarian cancers, how we can translate that to endometriosis. But before we get there, so when you started the mix rotation and working with Dr. Winner, was there any like shock or any like aha moment that, oh, endometriosis is like this, not that I used to see with these non-mix specialists, because typically that has been a common pattern. I'm curious about your experience.
Well, yeah, it's interesting because, I learned a lot in my residency, and I learned a lot about different diseases, but I think we weren't, specifically taught about ablation versus excision surgery. And I went on to do surgeries with Dr. Winter where she would remove lesions or scar tissue that I was not taught to really consider as something to be removed previously. We would get the pathology back and it would be positive for endometriosis. So for me, that was really eye opening, that, that I needed this additional experience and training to really identify the disease and be able to treat people and to excise it. And even though I had really, really great training during my residency. And so I think that was really eye opening, in that, why we recommend a surgeon that is skilled with endometriosis excision surgery, because I think some patients just aren't getting a good, to no fault of a general gynecologist that doesn't focus on it. They just don't see it enough to be able to find the atypical lesions. And I think also working in the clinic and listening to the patients, in residency, you have a whole, you know, patients of all types of different things, and you're doing a lot of obstetrics. And so being in a clinic where you're seeing endometriosis patients every day and hearing their stories, like, it's heartbreaking to see these women, predominantly of reproductive age, that aren't able to function and live their lives. And so I think that is that definitely motivated me to try to do something about it, and to use my expertise to help that population.
Yeah, I totally understand you. I think the recognition of the lesions, especially atypical lesions, it was probably one of the biggest revolution in endometriosis care. Just to know endometriosis presents in multiple ways, and I think that's I completely understand when you say it was like an eye-opening experience. But also, like, how far are you willing to go to cut a disease? Some people get uncomfortable. Some people, it's always risk versus benefit for every single decision. So the more you do it, the more you are willing to take risks, because risks go down in your. So I understand that it has been a thing that I've heard many times, regardless of what program or what residency they have been into. It's just it's not the focus of most trainings, but it's great that the MIGs exist and these surgeons exist to do that.
But it's hard because patients kind of just aren't aware of that in general. And so by the time they kind of come here, maybe they've had a few surgeries where they weren't excision surgeries, or, the lesions just weren't recognized. And so I think it's something, an education that needs to happen both for general gynecologists and for the patients to kind of be aware, for us as surgeons to be humble, which is hard to say of surgeons, but to be aware of your limitations.
Yeah, it's a interesting combination. On the practice level, you're an expert in uro and also endometriosis part. In the research and like molecular level, expert in cancer and endometriosis. And so you talked about the vaccination for cancer. What's your, I mean, and your background is a PhD in immunology. What will have to happen in the future to endometriosis? Are we going to have a vaccine? Are we going to have like an immunologic medication that goes target endometriosis? Is that even possible? Like, what's your opinion on that?
I hope it's possible. That's my dream for patients, because that's what they need. Because no medication eliminates the disease. The medications that we have suppress the disease, maybe slow it down. They don't make it go away, and they don't prevent it from happening. And it's in 10% of women. 50% are women that we work up for infertility. And so this is a disease that is very prevalent and um, can be very detrimental. And so I've done a lot of cancer research in my life, and immunology research, obviously, and I kind of view endometriosis as cancer like, in the fact that these are cells that have developed the ability to exist in an environment that is not where they're supposed to be. And that is exactly what cancer does. And even though it doesn't like lead to usually death of the patient, it does lead to debilitating disease in many cases. And so I think it's a very inflammatory disease. And as an immunologist, inflammatory is kind of just a buzzword for, like, we don't really know what's going on, but the immune system is involved. But when they look at lesions of endometriosis that have deposited along the peritoneal cavity, which is 80% of the disease, 80% of endometriosis is superficial disease on the peritoneum. And then the other 20% is the like endometriomas and the deep infiltrative endometriosis. And it's possible that all of these diseases are phenotypically a little bit different and need to be treated differently. But regardless of that, when you look at the diseases within the abdominal cavity on the peritoneum, which is the lining of the abdominal cavity, you find immune cells. And you find immune cells that have made a transition to kind of more the wound repair model. And those are exactly the type of immune cells that we find in tumors that are no longer being surveyed by the immune system. It's how the tumors evade the immune system as well. And so I think those similarities make a therapy targeting inflammatory mediators or immune cells a very promising therapy to help treat the disease. And there has been some mouse studies that suggest that as well. And so I think targeting either um, the cytokines, which are the molecules that the immune cells secrete that kind of foster the environment that is supportive of endometriosis, or targeting the immune cells themselves, or creating a vaccine that targets the proteins that are overexpressed in the lesions, just like cancer overexpresses proteins and that leads to them being cancerous. That's the vaccines that we developed at the Cancer Vaccine Institute. That's what they target. I think using that same philosophy and targeting the endometriosis could be really powerful.
Are you aware of any research or any team in the world that might be working on this already?
Yeah, there are some, there's groups looking at the different immune cells that are within the lesions. There's two arms of the immune system. There's this innate immune arm and this adaptive immune arm. Most people, when they think of the immune system, think of the adaptive immune because those are like the T cells and B cells. B cells produce antibodies. T cells are what kind of give you the very specific like antiviral or antibacterial response. But all of that is driven by cells called the innate immune cells. So these are things like you may have heard of like neutrophils, macrophages, dendritic cells, and those cells are actually what drives the response of the B and T cells. So my PhD was actually focusing on innate immune cells and focusing on dendritic cells because if you can learn how those cells are like activating the rest of the immune system, then you can learn how to control it. And so they find a lot of cells called macrophages within the endometriosis lesions. They find cells like these natural killer cells that are normally only found in the uterus within these endometriosis cells. And so targeting those cells, a lot of groups have started to look at targeting those cells. But in general, women's research is underfunded. So I think that there needs to be better funding to look at this research. And I think people that do this research for cancer maybe don't know about endometriosis, and so it's just an education too that like there might actually already be therapies that are in use for cancer therapy that could be beneficial for endometriosis.
Yes, I've been thinking about this question, like why cancer gets all this attention, like all this attention, all these fundings, but endometriosis doesn't. Maybe part of it is because cancer kills people within years, but endometriosis, no one considers it as a lethal disease. And also, endometriosis is just a women disease, and okay, that's okay. Women have pain in their pelvis, that's okay. I think it's a combination of factors that it doesn't give the attention.
Yeah, and I think it's like you said, those two factors I think are big for it. And then I think there's just it's not something that even as like OBGYNs, if a general OBGYN focuses on, it's just another disease that happens in women that they treat. And so I think there's just a general lack of knowledge of this disease and what it does to women and how it impacts them. If you think about it, these companies, I mean, it affects 10% of women. So if you can come up with a therapy, that's going to probably be profitable from a business perspective. And so I think just my guess is just a lack of knowledge of the factors involved in the disease, and we just don't know that much about it. And I think the world of endometriosis research is only starting to kind of take off really in the last 5 or 10 years.
I completely agree. There was this study done on. I mean, I agree with the word of endometriosis expanding in the last couple of years, but about what you just said that they don't. There has been a study that most of the pharma funding and research and development funding for new medications focused on the end stage of life. If they can have a medication to extend life by 2 months, that gets like probably 70% of all the funding. The medications that extend the life for 2 or 6 months. Then you have less more funding to go back. Then you have almost no funding for 10 years before the cancer. What we can do that we can get no cancer. Like no one pays attention to that. Part of it is who knows, whatever, maybe they don't have profitability, but the part of it is just measurements of the outcome is the problem for them. I don't know how to think about endometriosis in a way that is economically and commercially profitable for them, but there needs to be cases with, but as you mentioned, there's more conversations about all these issues and how profitable this could be to enter endometriosis community.
It is some, I mean, the vaccines that they're developing at the Cancer Vaccine Institute, there are some preventative cancer vaccines that they're working on. And so similarly, I think a preventative endometriosis vaccine could be powerful if you can get the disease before it even forms in these women, especially in, we know it's familial, so that would be a population to start in. If your mom or sister had endometriosis, you're much more likely to get it. The data is mixed on the numbers. I've seen as much as 50% chance of getting it if you're someone in your family has had it. And so I think the main goal would be to prevent it. And but you're right, like it's going to be hard for a company, to maybe see that as profitable, because to me there's also just the societal benefit of someone that potentially could have had the disease, and then they don't have the issues with infertility. They're able to work, and they're not taking sick days, and they're not missing school, and they're not, so debilitated that they are not being a productive member of society. So I think, yeah, it's really complicated.
Yeah, maybe the other complication about vaccine is some theory believe that endometriosis is in the body when a person is born. There is this whole idea that there are conflicting ideas, but probably most people believe in both of them, like the retrograde menstruation versus some genetic inheritary factors. But yeah, at least maybe even, I mean, the general idea is the lack of funding and knowledge that we don't get anywhere with the current funding and knowledge. We have to start developing, which is happening, which I totally agree. That's important. So how is the practice going now? So back to full spectrum and mature, this is part of your practice. So you're in Seattle. I think you are the first full spectrum practice, as is in your name, covers everything related to endometriosis. How has it been? What's patients' reactions? How do you feel? How do you see the reactions? Is there any first-hand experience you can share with us here?
Well, we're still pretty new. We've been only seeing patients since middle of December, so about a month and a half now, and we just started operating again in January, and so we haven't really had the opportunity to kind of long term see how patients are improving with this model. But as a part of the practice, and because I have a very research oriented mind, we have like a really kind of large intake questionnaire, and kind of to see how patients are doing. And then I'd like to be able to see if they work with our multidisciplinary team, whether that overall shows improvement in their outcomes, and so that we can have some data to say that this is really a good model to have for this patient population. And so uh, it's hard to say. We haven't really been open that long to be able to really answer that question. I mean, I know there's lots of patients that are very happy to be here. I think the majority of patients we ask on that questionnaire, do you want, which of our multidisciplinary services are you interested in? We currently are offering nutrition counseling, pelvic floor physical therapy, acupuncture, and mental health counseling. And I would say the majority of patients are wanting at least one of those, if not all of them. And so I think there's definitely a need for that, and for patients to see providers that are also familiar with endometriosis. The team that we have know the disease, they know women, and they are passionate about treating it. And so I think in general the patients are very excited about that, but I don't have like the data about outcomes and all of that yet.
Yeah, I understand. I mean, it takes obviously, I agree, it takes time. And so, can you share what data you are tracking? I mean, if you don't have, if you can't because of confidentiality, it's okay. But
Well, just kind of it's outcome driven, and so it's like pain scores. We're looking at pain scores, patients' symptoms. It's more kind of just their perception of how they feel. We haven't really we've just done the initial questionnaire. We haven't gone to the other side of it and kind of the follow up questionnaire, because we haven't been open enough yet to really accumulate that. But over time, I'd like to see if they're telling me they're coming in with pain, pelvic pain, painful periods, heavy periods, urinary symptoms, pain with urination, blood in the urine, bowel symptoms, pain with bowel movements, blood in the stool, diarrhea, constipation. Like all of those things are a part of the questionnaire, so that we can go back later and see, have you had improvement in any of these with regard, and what modalities did you also use as a part of your treatment.
that's great. I would also be really curious. Maybe you also have these questions in your question about their quality of life and productivity.
Hmm.
Because there are studies that show patients with endometriosis spend about 14 hours of their productive time managing their disease, not endometriosis, chronic conditions. I mean, obviously endometriosis is one of them, but I would be curious how this can impact the productivity and also time loss before and after, or how long after your implementation of your model for the patients. But that's really cool. I'm really interested in seeing the results of these studies that you're running, because in many ways you're offering some unique multidisciplinary approach, which if it shows results, it could be incredibly helpful and scalable and can be adapted by other centers.
Yeah, hopefully. I mean, that's the goal. And I think, there are a few of these kind of centers popping up, and I think people are starting to realize that there's a need for this, but definitely data helps.
Yeah, yeah, data is like the number one driver of this. Okay, so what's next for you personally? Is there any fellowship in your radar? Is there any like what, or you want to stay here and focus and improve your skills?
Well, yeah, that's a good question. I think right now I'm pretty committed to staying here and keeping kind of expand my skills. I operate with Dr. Winner. All of our surgeries we do together, so I get the benefit of her surgical expertise and the fact that she's been through a fellowship. It's kind of a unaccredited fellowship, I guess, kind of in the fact that we just work so closely together. I think for my general like career, probably going to do a fellowship would be beneficial, but also I just feel that what I'm able to do here is so unique that at this point, this is where I want to stay and I want to help build this practice and make it successful and take it from there. And so, uh, it'd be good to have the fellowship title behind my name, but at this point, like, I don't need it. And I feel like this is where I'm able to do more and really help patients.
Okay, I see. Yeah, it makes perfect sense. I mean, I know a lot of really good surgeons who have done non-accredited fellowships, still equal quality, equal skill level. It was just fully focused on one disease or two, like yourself. So yeah, it makes perfect sense what you plan to do. And so I'm gonna ask a couple of questions. It's more on personal level, just to know you a little better. I think you're gonna. So you are, in my opinion, like we have a lot of surgeons from a few years out of residency up to 40, 50 years out of residency. In this spectrum, I think you are on the like side that it has fewer years out of residency. So I would consider you one of the younger generation of the endometriosis experts that are basically taking lead in this. So we are gonna hear a lot of things about you. I wanna bring some personal aspect of your life to the community
Okay.
to help with that movement of your brand and your practice. So your mom is an artist. She paints, right?
She does mixed media, yeah, but she's an artist. That's correct.
Yeah,
I do not have any of those artistic skills. I wish I did.
that's my question. Did you inherit a part of that?
No, I can't draw. I can't paint. I do not have that gift, but I appreciate that she does.
Okay, she does it for both of you. That's awesome. And so you purchased some of the paintings for the practice for the exam rooms, right? Do you have anyone in your background that you can show us now?
Not my mom's, but yeah, so each of our exam rooms, we took art from a local artist and we kind of have four pieces from each of those artists in each of our rooms to kind of just make it interesting, something to look at. And since my mom is an artist, we chose four of her pieces to put up. We didn't purchase them; she kind of just let us do that. But we made prints of them, so they're not the originals. But yeah, I think it's when you come into the clinic, you get to see the art. One of the artists actually had endometriosis and has been very vocal about that and did her art, was not able to do her art prior to her surgery and then had surgery and felt so much better that she was able to do her art again. So a few of the pieces in the office are the initial pieces that she made as she was recovering from her surgery and was finding her love and ability to do art again. And so I think it's really inspiring to have that in the clinic, besides just being really beautiful to look at. In one of the other rooms, we have one of Dr. Winner's neighbors is a photographer, so we have some of her work. And then in the other room, we have electron microscopic images of hormone molecules. And so kind of all very interesting and unique.
Do patients get to choose which one they want to go to?
I guess not right now. They could. I guess if they saw one, if we posted pictures of them, and they had a preference, I think we would accommodate that if the room was open.
Why would put so much spiritual aspect to this, like touches that aren't physical, aren't medical, right? What are hospitals? You get in like bunch of do's and don'ts, like zero tolerance policy, a bunch of things now, wash your hands, mask, and get in the room. We examine you out of the room as quickly as possible. That works. People need it. But then you come and do this stuff. Like this is like personal touch, local touch. This is very meaningful. I think it adds so much to the spiritual experience of your practice. Why? I mean, why would you even need that to be in your practice?
I mean, I do pelvic exams every day. They're not fun. They're not fun. Patients don't love them. It's not like you want to go to the gynecologist and have an exam, but it's necessary. And I think because we built this practice outside of that sterile hospital environment, we had the opportunity to make it more of a place where patients feel that warmth and comfort. We kind of wanted to make it more spa like, especially because we also have our multidisciplinary team that's here, and that's kind of the environment that they are used to. And so we just want to offer little things to patients so that they feel very welcomed and that they feel very comfortable. We have a lot of little things. We have a coffee, tea, and snack station when they come in. We have charging. We have Wi-Fi. Some studies have shown that lavender satchels or lavender can help with your perception of pain during a procedure or an exam. So we offer little lavender patches, little affirmation warm stones, just to kind of make you feel good. Lots of little touches. I think that when someone comes here, they don't think this is the typical gynecology clinic that they come to, and we want them to feel those little touches, and we also want them to come back. And so I think that's why we kind of try to create this environment.
Yeah, I think that's really great, and I really appreciate you doing this because part of the healthcare problem, in my opinion, is just like not caring about patients' experience in total. Like, of course, that ultimate value is delivered between doctors and patients' interactions. No one questions that. But patients' experience start from the moment they step in that environment. You can't erase that by any means, by any good service or any good surgery. So that's super important. I really appreciate it. I was really impressed by the vision that you had, and like all the pictures, the things that I saw, I was like, these people are thinking completely differently, and I really like the way that they think.
I mean,
So
love
that's
going to a spa. So,
right.
like you want to come into a place and just feel warm, or even just to have the rooms be warm. Like to have to do an exam and get undressed and be in a cold room is miserable. So, keeping the office warm is, really nice. It's nice for us that work here too.
I completely agree. Like exactly, even you are gonna like that space to go to every day. It's not just patients.
Hmm.
Yeah, there is a lot to learn from you, I think, by healthcare systems. But maybe when you show the impacts and the results, then at that point people would be curious what's happening. Then many people want to learn from you and copy what you have done. But it's hard to be the first mover.
Yeah, we'll see. We'll see. But I think our patients enjoy it, that experience, and so we're glad to be able to provide it and to have this model that we can do that.
Awesome. So, do you still do triathlon?
I do. I do. I'm going to do a half Ironman this summer in my hometown, actually. They just announced it last year, so that will be exciting. I'll get to see a lot of my friends from when I started doing it in St. Louis, so that will be fun. Right now, I'm not allowed to do full Ironmans because it's just too much training. It's almost like having another job, and so a half Ironman is more like kind of training for a marathon, so it's more manageable.
So, your hometown is St. Louis.
No, it's Rockford, Illinois, which is about 5 hours from St. Louis. But because it's so close to St. Louis, a lot of my friends that do triathlon that I met in St. Louis are going up to there because it's just one of the closer races to St. Louis.
Do you get time to practice?
Yeah, I get up in the morning and try to run or bike or swim. It doesn't happen all the time. It's especially hard on operating room days because we start early, and sometimes they go long. So those are the days where kind of the training falls through the cracks a little bit. But for the most part, I try to fit it in as much as I can.
I'm so glad you're doing it. A lot of the people that I speak with, when they get involved with endometriosis, they somehow give up exercise and any physical activity, which I think shouldn't happen. But for some reasons, people get so invested and focused on the disease that they forget about their own health and exercise. So I'm glad you're doing it. I'll keep reminding you every year to
Yeah,
keep doing.
it's hard. I mean, it's definitely hard. I definitely have had periods where, if something is going to give, that's what gives, you know. That, sometimes work comes first, and that's the type of person I am. And so unfortunately, the athletics is what falls to the side when I have to devote more times to other things. But I try to manage it, because, like you said, it's better for my health overall, my physical health, my mental health, and if I'm better, then I'm going to be a better doctor.
Yeah, that would be great to keep doing this. And this is my last question, and then you can ask questions if you want to. Or what are you thinking about? What keeps you up at night now that you have started this? You have joined this new practice, and you're building a career about a complex disease with a lot of complex complications. And so, what keeps you up at night? Is there anything that you can share?
Think two separate things. One, we're building this practice, and there's a lot in building a as a everything I've gone through is not business and has not taught me how to build a practice. And so there's a lot of little things that come up every day that we have to troubleshoot. And so that lately has been keeping me up at night and making me think about, how do we kind of make us efficient? How do we make this work? What do we need to do on the business side of things? And then from more of a scientific point, is what resources can I use due to my knowledge and my background in order to move the bar in terms of the research regarding endometriosis and potential treatments regarding endometriosis. And I think for me, it's always going to be a constant struggle of, how much time do I devote to the clinical side, and how much time do I devote to the scientific side? And, am I better suited to be at the bench, or am I better suited to, be a consultant for the research side? It's something that I never want to let go. And so I'm constantly trying to figure out how to make that work, and to keep that a part of my career and my life.
So that PhD part of you doesn't let you.
No, it hangs on. It was hard to get through, and it's persisted. So it's always going to be a part of me, and a part of who I am, and what makes me it makes me how I practice. It defines how I practice and how I think about the world. And so I think, specifically, my expertise in is very unique and very applicable. And so I want to, you know, utilize that, but also I'm really passionate about being with patients in clinical care, and I don't want to give that up. And so it is a constant struggle, and you'll probably hear that from a lot of MD PhDs, because the system is not built for us to really be able to do both anymore. And so that's why right now I'm focusing on the clinical area, but I'd like to figure out a way to contribute to the research side in the future.
Yeah, that's great. I think this is exactly what we need. Different people, different perspectives, backgrounds, education backgrounds, and paths to come into endometriosis bring new perspectives. Like I never thought of having a vaccine for endometriosis, right? Who would even think about this except someone like you, right? To bring come and tell us, look, there is vaccines for cancer being studied and developed, and the whole process could be similar. Why not thinking about that anymore? So I think that's very valuable for the community. Although the community is pretty young, as you said, it's just the whole knowledge and thing has been like 5 or 10 years. Although the disease goes back as long as humans go, but the actual movement, the energy that we see now has been like here for 5 or 10 years. So I hope that you keep doing what you're doing and building new ideas and new knowledge for us, because I think we really need that.
I hope too. That's why I'm here.
Awesome, and thank you so much. Is there any last word that you want to say to
No,
patients?
I appreciate you having me and being able to talk about this today. Yeah, I have to promote our clinic. It's full spectrum fibroid and endometriosis in Seattle. Should I say our website?
Yeah,
It's www.fullspectrumgyn.com. And so that's where you can find Dr. Winner and myself.
Awesome. Thank you so much, Dr. Kretzer, and really appreciate your time.
Yeah, thank you.